you so much for tuning into our first Facebook Live broadcast on the WealthyMe platform. We are so excited to be live this afternoon, and we're also excited about the discussion that we're going to have. Today, we're going to speak about healthcare, and more specifically, we're going to discuss the issue with NHI, the link between NHI and COVID-19, and also member contribution increases for 2021. This afternoon, we have Clayton Samsudeen with us, the Group CEO of Phoenix Financial Services Group, and we're excited to have him here. He's going to help us, and he's going to help us make sense of this healthcare issue that we want to dive into this afternoon. Now, COVID-19 has really exposed the inadequacies as well as the inequalities in healthcare systems globally and also in South Africa. This afternoon, we know that South Africa is in the recovery phase, and what we need to evaluate is whether or not COVID has assisted in the rollout for NHI, how that will impact on medical schemes, and also the increases for medical increases for 2021. This is our first live. I am naturally a bit nervous. Please bear with me. I'm going to introduce Clayton. Clayton, thank you so much for tuning in today. It's good to have you on this platform.
Thank you, Regan, and thank you for the opportunity, and welcome to the listeners. And thanks for the kind introduction. So just quickly, Phoenix Financial Services Group, as many of you know, were birthed in the midst of the pandemic. And the name Phoenix signifies the birth of an re-emergence of a stronger, transformed, creative group in the financial services sector. And we're in the business of securing better benefits for more people in the areas of assist, support, wellness, healthcare, financial planning services, insure. And our main aim is to improve the quality of life for all. So thank you for the opportunity and to allow me to introduce Phoenix. Appreciate it, sir. Thank you.
Clayton, yeah, we have to commend you for starting a financial services group in the heart of COVID. We have to commend you for that, and we wish you well with the journey ahead. And we thank God that we can be part of your journey.
Thank you.
And that we can support you on your journey. So, you know, let's maybe just dive straight into some of the questions that we'd like to ask you. Do you think, Clayton, is there anything that we've learned from COVID-19 in terms of rolling out the national health insurance in South Africa, or NHI, as some of us refer to it?
Thanks, Regan. That's a very important question, because I think firstly, one of the things we immediately picked up was that the country was really ready. I think our government made important decisions from the very get-go. And we went into an early hard lockdown, which I think a lot of other countries were battling with. But I do think one of the biggest learning things were issues of information systems, particularly in the public sector. So if we're talking about that NHI is going to run the health system, and we see that the information coming out of the public sector is a bit anemic in comparison to private healthcare and the information we got out of private healthcare, we understand that information could have been better from the government side. But I also think that, you know, one needs to have a balanced view. If you think about that, we haven't had a shortage of medication. Medicines was in good supply. Other countries were running around looking for ventilators. We didn't have that. We didn't have issues of, you know, where we didn't have space for burials of people. We didn't have people with corpses not being kept in mortuaries. So, you know, I think all in all, things was really good. But I think one of the other great learnings was the unification between public and private sector, because it was a joint effort to fight the pandemic. You know, we always had this thing about, is medical aids going to exist in an NHI environment
Mm.
and all of that. But really what we see now was that it coming together and uniting to fight the pandemic, which was great. And I think that sets the scene for the parties coming together for NHI.
That's a nice balanced view. So what you're saying to us is the weaknesses that we've seen in government information systems versus private healthcare systems is the information that has come out, but also in terms of the positive side of things is how we've collaborated between public healthcare as well as private healthcare and how we've unified. That's an interesting view. Clayton, during COVID-19, we've seen this phenomena with regards to excess deaths. We know that there's kind of a forecast of how many people should die on a monthly basis. And what we've seen now in COVID, and even now in October, we've seen this excess deaths and the number increasing. Do you have any insights to share on that today with us?
Yeah, thanks, Regan. I think it's no rocket science. When you read the reports from the NICD and reports that came out of Wits Health, what you actually see is that the excess death is trailing the infection rates.
Okay.
So if you plot infection rates and you plot excess deaths, they almost follow one another.
Okay.
And so you conclude that the excess deaths are actually COVID deaths. But the big question is, why did that occur? So were people turned away at public facilities? Did they not go? Did they not get access to health services?
Okay.
And why is it not kind of noted as COVID deaths?
Okay.
But the fact is that if you just look at the algorithms, it suggests it's COVID deaths.
COVID deaths.
Yep.
Okay, so that's quite interesting. We know, Clayton, that NHI is set to launch in 2025, 2026 financial year in South Africa. That's the plans. But we also know that South Africa, the economy is not doing well. Our debt to GDP ratios are growing. I mean, the finance minister this year, we projecting our economy to contract at almost 8%, and that's huge. The question that we're all asking is, does South Africa, in the context of COVID, in the context of our GDP, debt to GDP ratio, in the context of our economic growth, do we actually have the money for NHI?
So I think the first thing is we need to understand how is NHI going to be funded? What's the proposals on the table? And the proposals is that there must be some form of tax.
Okay.
Of course, there's other things of reining in tax credits that medical scheme members receive. But I think where the big issue here is that the taxpayer is already overburdened. And if you're going to put another layer of tax in, I think tax specialists and governments will all agree that we're going to get to a point where you're going to collect less tax revenue instead of more. And so you can't overburden distressed kind of consumer and taxpayer any longer. That's the first consideration. The other consideration is that if we now currently, our borrowing rate is 80% of GDP, and if we do not actively manage down corruption and state expenditure, and we have all the state-owned enterprises, well, most of them in a deficit requiring bailouts, if we don't deal with that, we will sit in a situation where our debt to GDP ratio will exceed 100%. If we then fast forward into 2025, 2026, and understand that the cost of NHI is going to be another 33 to 55 billion, then I don't think it's feasible to see the country being able to afford NHI in the short term. And I think that is very unfortunate, given the fact that we actually need healthcare access to healthcare to deal with things like a pandemic efficiently and effectively. So I think it's a challenging time, and I think we need to really manage down the cost, particularly in the government sector, in order to afford NHI later. But adding another surcharge onto pay as you earn or to another layer of tax is just not going to work. I think we're just going to land up, and we can see that because if you look at the tax collection from the South African Revenue Services, we tend to be collecting less tax. So if you're going to add another layer, you're just going to collect less tax again. So I don't think it's a feasible scenario.
So I hear you saying, I hear you mentioning the situation with adding tax. So NHI, suppose it goes live, suppose the goalpost doesn't get shifted again. What happens to medical schemes in our country? Because at the moment, people that can afford medical aid, that's almost like a double tax. To get access to good quality healthcare. We know that government is supposed to provide good quality healthcare, but many don't have the confidence in government to provide the healthcare, and many people are comfortable with having their medical schemes and having access to private healthcare. Yes, we understand there's inequality in the country. What happens to medical schemes and in a NHI world?
So what we're finding is that in simple terms, medical schemes will provide, is said to provide complementary benefits. So medical schemes will exist with NHI, and medical schemes or any other type of insurance won't be able to duplicate benefits that NHI provide. Okay. So what you'd find is that NHI provides a basket of benefits. Medical schemes would then provide a top-up to that. And so typically, we predict that medical schemes would become more affordable in an NHI environment simply because there can't be a duplication of services. I think what the other important scenario is that there's another product in the healthcare environment called gap cover.
Yes.
And it is said that gap cover will exist in an NHI environment with medical schemes being offering complementary services. So that would be the lay of the land in an NHI world.
Okay, that's quite interesting. Clayton, the next thing that I'd like to ask you, we saw the announcement that came through from the Medical Schemes Council with regards to medical premium increases for 2021. In actual fact, they're proposing that medical schemes actually freeze the contributions for 2021 or increase it by a maximum of 3.9% for 2021. Now, we know that medical inflation in this country is extremely high. As an active medical aid member, every year when you get your statement, it goes up by 8%, sometimes 10, 11%. And I mean, as a medical aid member, I welcome the proposal by the Medical Schemes Council. But how has the market reacted to this recommendation from the Medical Schemes Council?
That's a very good question and a good point, Regan. I think, firstly, it was a complete about turn from the Council for Medical Schemes. Previously, we saw increases of CPI plus 3%. So if CPI was at, let's say, freeze the medical scheme increases or limit it to 3.9%. And that's because consumers are financially distressed because of COVID. Another important factor is that Council is trying to get the increases in line with inflation, which is an important scenario. I also just want to add that, so how did the market react? So fortunately, we had a number of the top medical schemes that limited the increases to 3.9%. So they adhered to Council's request.
Okay.
We had the largest medical scheme that had a 0% increase. So they actually froze the increase up until July 2021.
I think that's Discovery, am I right?
Yeah, you can mention the name. I'm not going to mention
I saw
the name.
that. I saw, they're promoting it. Yeah, so that's
correct. Yeah. And so, you know, there's negatives and positives to that. So for 6 months of the year, people won't have an increase. And then there's some people that would argue, well, I'm having an increase in July, but then 6 months later I have another increase. But I think it's 6 of one, half a dozen of the other. But look, luckily we landed. If I looked, we did a snapshot survey, and we landed up with an average increase of 5.2% on the top schemes, and that's great. I think it's really great that we could come in at a lower increase than what it would have been in previous years, and that sets the scene for the future. I think it's really trying to see how can we do that. And how is that possible? I think that's a big question. How did we get there? One of the reasons it was possible because during COVID, medical scheme members, one, did not go and do their electives like they would previously. So medical schemes sat with significant surpluses because members did not claim, they did not go for electives. And so we kind of holding our breath that we don't see this surge back to doing electives in 2021, driving up the claims ratio. Yes.
Electives. Can you maybe just explain to our viewers, you and I may understand electives, but maybe just explain to our viewers what you're referring to when you're saying electives.
Okay, so an elective procedure is where you decide as a member you want to go for the procedure. So a simple, since we've just come out of breast cancer month, maybe I should use that.
Okay.
So a mammogram is an elective. It's something that you decide you're going to do for preventative and screening tests to ensure that you don't have breast cancer. So a mammogram is an elective that you do that you decide. However, there are times when you would be recommended or suggested to go for a mammogram. So what we've seen as an example and I'm latching on to breast cancer month. So what we saw was that an almost 46% drop off on females not going for elective mammograms, and that's massive. So the drop off is significant, and so you can see how this plays off in other elective surgeries. So electives is when you decide you want to go for something, and of course an emergency or other treatment is when you're required to go.
Okay, so the schemes have kind of saved a lot of money.
That's correct.
And that saving they've not pocketed, they've rather given it back into reducing the increases for members. I've got a question there from LJ Haskins. LJ Haskins wants to know, in a post-COVID, not post-COVID, post-NHI, will the government build more hospitals, or will we just use the current infrastructure that's available in private healthcare and so forth?
That's a very good question. I think the first thing, going back to what we were saying about what did we learn out of the COVID scenario and the rollout with NHI, what I do foresee is that there'll be more public-private partnerships. We'll see that some hospitals that are private hospitals will be enlisted for NHI. We'll see some doctors, your normal GP specialist, that would contract with NHI, and that would increase the reach of NHI. And yes, of course, I mean, we demonstrated capabilities in the country that I'm exceptionally proud of. I mean, building a field hospital in 3 weeks, it just shows you what we are capable of doing and things we must be proud of. So people go ramping and raving about the PPE corruption, and I'm saying, but guys, at the same time, we didn't have medicine shortages and ventilators, and you got to look at it in that way.
Awesome. I think I want to take another question from Cindy Lee. As noble as NHI may appear to be, do you think it will ever be realized? And if it's not funded by taxpayers, how will it be funded?
So access to healthcare is enshrined in our constitution.
Okay.
And therefore, Cindy Lee, I can assure you that NHI will be realized. It may not be realized in 2025, but we will have NHI. And how it's going to be funded it's a complicated mechanism. But at the moment, we have medical scheme members receiving a tax credit. We have money going to the provinces. And it's a matter of allocating that funding properly. And it's a matter of doing a proper financial analysis and plan. And it's also a scenario of just having to apply finances and all of that correctly. But I think we also got to understand that if we did not have COVID-19, and if there wasn't the drop-off of 2.4 million jobs, and if the economy did not shrink by 7.8 million, we may not have been in the situation that we are. And we very well have reached NHI by 2025. So you got to understand, what COVID had done. The impact is significant in terms of delaying the possible implementation of NHI, but it will come. It's part of our constitution.
One of the questions that I want to ask you as well, thank you, Clayton, is I think you've quoted it. I think more than 2 million people has lost their jobs in South Africa. Many of those might be members or were members of medical schemes, be it a closed scheme or an open scheme. People were retrenched, and being used to having a medical aid and seeking private health care, is a privilege. But now you're retrenched, you're without a medical aid. Is there some sort of relief, like the banks gave 3-month holidays, insurance companies gave some sort of relief? So if I'm a medical aid member of, let's just call it Discovery, and I was retrenched from my job, and the reason why I had that medical aid was because it was a deduction from my salary at work. But now I'm without a job. Does that mean immediately I also won't have access to private healthcare because I can't contribute towards my medical aid premiums?
Yeah, so I think, Regan, it's a very unfortunate situation, and my heart really goes out to people that have been negatively impacted by the pandemic in so many ways. But I do think that what we have is a situation where there were payment holidays that was allocated. The Council for Medical Schemes decided that it cannot be a blanket across the board on all medical schemes. So Regan, what had happened was it was on a scheme per scheme basis, and every scheme had determined its own mechanism to do that. There were also payment holidays given to companies, small companies. So there was a dispensation to help people. On the other end too is that we find that people tend to cover themselves for major medical expenses, so almost a hospital type plan with chronic, and not, so we're talking about the downgrade now. So paying less for the medical aid, or moving to something called a primary healthcare plan. And so primary healthcare plans are typically around 60% cheaper, more affordable than a medical scheme. And so people either trying to ensure day-to-day benefits or major medical, but there are options. And in a pandemic, what we find, the trends are people would sooner cancel everything else and reduce all other expenditure, but they will maintain their healthcare cover.
Yeah, I think in South Africa, you don't want to compromise your healthcare, knowing the state of the public healthcare system, and we hope and pray that that improves in our country, because we don't always want to be against government. So Clayton, I think we're coming to a closing, because we don't want to keep people here for the entire lunch hour. Being a member of a medical aid, I just want to ask you this question. I get the feeling that medical aids are shifting some of their risk to the members. Why do I say that? You go to a doctor, you go to a hospital, you get the treatment, but there's always a bill that comes back to you after you've consulted in the healthcare space. And then you ask yourself, but why am I paying 6 grand, 7, whatever you're paying a month? But around every corner, I need to pay 2,000 rand there, 5,000 rand there. Why is that? And what can medical aid members do to avoid that?
So, look, I think one of the things that we should have realized was that council should not have changed the name from medical scheme. It was medical aid, so it's like an assistance thing, meaning like it doesn't pay for everything. But I mean, that's just another topic. Look, I think medical schemes don't pay for everything, and that is why we have something called gap cover. And gap cover closes the gaps that exist between what is charged by private health professionals and what medical schemes typically reimburse. And then there are other gaps, and the gaps you're referring to are things like co-payments, deductibles, sublimits, co-pays on things like cancer cover, and so forth. So I think what you find is that most people don't know about gap cover. Most people don't know how that fits into the medical scheme. Most people don't know that gap cover is an additional 140 Rand as a start off, depending on the type of plan that you join. But I think essentially you cannot have a medical scheme without a gap cover. And remember that in most instances only cover you for your major medical, where there's difference in rates that is significant material amounts of money. But you kind of can't have the two separated. But I think you make an important point, because the gaps in cover is increasing, and members that have gap cover are protected. Members that don't have gap cover are unprotected. So that means if I have a gap cover, what happens is I get to just shift that gap to my gap cover policy. If you don't have gap cover, what happens is you have to put it out of your pocket.
That's true.
So so that's the challenges that we have with gaps in cover. But my recommendation is to look at the gap cover policy.
Fantastic. So we're not here giving you advice. That's a very important disclaimer. We've almost come to the end of our broadcast. Clayton, in closing, are there any closing comments? How do people get hold of Phoenix Financial Services? Any closing comments from your side?
Thank you, Regan. So I think we're in the middle of not the pandemic also, but the medical scheme year in review. And so most medical scheme members have the opportunity to change the medical scheme options and submit that up until around the 30th of November for the 1 January. And I think it's really an important time because of everything we're talking about, you know, finances and all of that, for you to really just review your medical scheme option and decide what would be the best for you and your family. And you got to just sit down and do that analysis for 2021. To reach us, you can go to our website, www.phoenixgrp.co.za. And the reason for that is simply our systems, as you know, is all cloud-based. It's a whole revolutionized business. It just works better that way. And so we prefer to channel all our queries and inquiries through the website.
Thank you so much, Clayton. I think for us, from WealthyMe side, we just want to thank you for gracing us with your presence and for agreeing to be on this platform. To everyone that's tuned in this afternoon, thank you so much. Thank you so much for the comments. Unfortunately, we can't take all the comments. Connect with us on Facebook. Subscribe to our newsletter. We also have a YouTube channel. You can subscribe to our YouTube channel. Thank you so much once again, and have a lovely day. God bless you all.
Thank you.
Bye-bye.
Thank you, Regan. Thank you.
Thank you.